Hello, my name is Ronan Foley. I'm a hematologist at the Juravinsky Cancer Center in Hamilton.
I'm John Krivilla. I'm a hematologist working at Princess Margaret in Toronto. And we're both here to talk a little bit about some of the data that was presented by Sat Vanilapu in our cell therapy session at the Winter Hematology Update 2021. So with that, Ronan, we've seen a lot happen in cell therapy over the past couple of years, and we've finally seen standard of care CAR T come in large cell lymphoma to Canada and particularly to Ontario. So SAT was started with looking at large cell lymphoma and quickly reviewing the three pivotal trials, two of which are now approved by Health Canada and funded, and we're hoping that the third one with liso-cel will soon be Health Canada approved and hopefully funded. So, maybe with that as a bit of an introduction into the landscape, he summarized a bit of the data. Do you want to highlight any take-homes before we get into the first study that he discussed, which was ZUMA-12?
Yeah, no, thanks, John, and good to see you. This really was quite a remarkable talk. And just as you said, I agree 100%. Things are happening at breakneck speed. It's been just a short while that we've had CART, but this talk really exemplified how much is happening in the lymphoid space, and really how important it is to stay up to date. So congratulations for this talk. I mean, I think it really did that, but also just reminded us how quickly things are happening. I mean, ZUMA-12 is just an example of how quickly things are moving up. I particularly was quite impressed. I know it's an interim efficacy assessment, but the efficacy was better in kind of as the pitch is made using a therapy earlier on, not just for people who need it, and instead of potentially doing therapies that are less likely to work, kind of getting to the therapy that has the most chance. But it also, I think, in my mind, suggested that better lymphocytes, more fit lymphocytes earlier into the journey, and it certainly was some evidence that the expansion and persistence and activity of the lymphs were good. So I mean, all around it, just to me, that was a very exciting trial in ZUMA-12. What did you think?
Yeah, I mean, it was, definitely from a proof of concept study, an important thing that needed to be done to move CAR T into the frontline setting and ask a question from a feasibility standpoint. Could you give the therapy safely enough? So the toxicity signal, I think, was very reassuring. And, the big question is really the efficacy question. And we know historically, people have tried intensive therapy like stem cell transplants and have identified progression-free survival advantage in high-risk populations defined by the IPI. In this study, it was interesting because they looked at the group of patients we struggle the most with, double hit or triple hit lymphoma as one inclusion, but also really highlighted the use of a biomarker using PET scan after 2 cycles as a way to identify high-risk patients. And so, I think that leads us to some difficulty in terms of interpreting what the efficacy means. And, if this was ultimately a positive phase 2 study, when then you say, do we take it forward and do we roll the dice on a randomized trial looking at CAR T up front? And so I think they accomplished their goal in that it was safe. The translational data, as you highlighted, looked really good, that, earlier collection of T cells, those T cells were fitter and probably going to be more effective when compared if they were head to head against a later T cell product. But, I think in the lymphoma field, you're still left with the question, this wasn't a home run. It wasn't a perfect treatment in terms of efficacy. And so we would need the follow-up randomized study to really know if you could successfully move CAR T into the front line. And I think that's the challenge for us. And in Canada, since we don't do PET2 in DLBCL, trying to apply this in our practice is still a couple of steps away.
Yeah, no, I agree, and certainly still represents an unmet need for these very refractory patients that declare themselves early on.
Yeah, so I know we've discussed the mantle cell lymphoma as probably being the next major change to come in the lymphoma space with CAR T cell. And so again, Sadva showed us some of the longer term follow-up that's starting to come with their X19 product and mantle cells. So do you maybe want to give me a sense about where you think things are going there?
Well, look, there's a lot of buzz about Zuma too. I mean, it's you hear it all around. When's it coming? And so I think we're all excited about it. Again, I think the efficacy data at about 66% CR is very good. I think these are patients that are probably going to transition off BTK, and there's this kind of somewhat compelling data. I think from the CLL groups that ibrutinib and CAR T seem to work well together. Whether you get more CAR Ts or whether they're more fit mechanistically, I'm not sure, but it certainly seems to be the case in CLL, and you could argue mantle cell if people are going to be on ibrutinib. I guess the only caution I'd have about ibrutinib and CAR T is I just want to make sure there wouldn't be any cardiac signals or toxicities in doing that. But no, I think it's just more supportive data of why everybody's excited about Zuma 2, and I think certainly in Ontario and Canada, we're ready to go with it.
Yeah, like I kind of find that this is probably that population we struggle the most with in Canada right now, because in patients that have had ibrutinib and then progressed with mantle cell, what do we have left, right? So we don't have funding for drugs like venetoclax. We don't have funding for combination approaches thereafter that look that good. Patients might have had an autologous transplant in first remission before this happened. They've probably had bendamustine if they were older and maybe not transplant eligible. So, in terms of novel active options, we don't have much. And, as I know you will see these cases in your practice too, you start to think a little bit about, is this still that group that you might think about non-myeloablative allogeneic transplants in, where there is some good data with follow-up. But I think for me, I look at Zuma 2 and say, here's our new gold standard post ibrutinib. And, we don't have access in Canada. And so I think the concern in the short term, it's not like large cell lymphoma, perhaps, in that, we don't have anything at all. But I think we're still left in a place where for Canadian patients, this is probably going to be the next big ask. And hopefully it will get funding quickly, or we may need to be starting to think about sending patients out of country again if we don't have it available for us in the province.
Yeah, I couldn't agree more. You're 100% correct.
And it was nice, he also showed, so the data with liso-cel, which was published in the Transcend study, they've shown similar data. So again, proof of concept, much like what we saw in DLBCL, that whether it's 4-1BB or CD28 co-stim, both the platforms look active. There's good signal. It's reassuring. So these are, again, it's more than one phase 2 clinical trial that shows the benefit. And I think we can be more confident that we're, potentially going to be offering a treatment that has good efficacy moving forward. So it's kind of nice to see that again. And, as we were talking just before the session started, Ronan, you'd mentioned that some of these early results, as we now kind of look to indolent lymphoma, so follicular or even marginal zone, we're starting to see a recurring theme here about 19-directed CAR T cells.
Yeah, there's no doubt the Zuma 5 data was interesting, and they also talked about Alara with very similar results. So again, kind of really fantastic results. I mean, I think the thing in lymphoma, as you well know, John, it can be an indolent disease, and trying to understand what is the outcome measure we're going to be able to use to determine how good this therapy is in relapse refractory indolent lymphoma. So I think that's going to be the challenge. I think we all know, I mean, lymphoma patients are supposed to do really well, but you get this 15 to 20 to 25% of people that just don't do well. Maybe people that are progressing on active chemoimmunotherapy, people with a bad POD24. I don't know if the FLIPI-N7, if there's some genetic interrogation, but clearly, I think now the focus is on two things. The focus is on identifying who are these people that are likely going to do poorly. And then the second thing, as you suggested, I think this is going to beg for randomized trials to because the outcomes aren't as clear as they were with diffuse large cell lymphoma with Scholar One. Now I think you really have to prove it in a prospective randomized manner that this is the way to go. And of course that's going to take time. And strategically, I suppose if you really kind of are able to pick the bad actors, then the signals should come in fairly in a timely manner. But that's kind of the challenge there for me.
Yeah, I think you're right. The interesting thing, again, much like with mantle cell, much like with DLBCL, we have this consistent efficacy signal. It's there in both of the studies. The ORRs, the CR rates look good. The PFS early in an indolent lymphoma looks encouraging. There is no Scholar One, as you said, and I know there's some attempts now retrospectively to try and identify match cohorts to really look at the magnitude of difference in terms of PFS. But time will tell. And maybe I'll put you on the spot a little and ask you a technical question here, looking at 28 versus 41BB. So in indolent lymphoma, where I think we're going to be much more cautious about toxicity to the patients, there may be a differentiator here in 28 versus 41BB, because the toxicity for the Novartis study, if anything, looked even a bit better. And the toxicity in ZUMA-5 looks pretty good. But I'd be curious to see what you also think about in indolent lymphoma, where with 41BB, the idea is there should be more persistence of those cells. And is this an area in particular where maybe the co-stimulation of the product is actually going to be differentiating for the drugs?
Wow, that's a great question. So, I think this is going to be very important, and I think it's a reminder, and I think Dr. Nilapu's lecture did kind of remind us that there's so much we need to learn about graft composition and what the effector cells are doing in these patients. So I don't think we're going to ever be able to get away from that. I think we're going to have to get more sophisticated about persistence and potentially mechanisms of relapse, and which co-stimulator is doing what. I believe there are differences based on the rate of expansion and aspects of memory and whatnot. So I think you're 100% right, but at this stage, I don't think I'm willing to commit one way or the other. But it just says to me, we do need more translational research to more fully understand what's happening at an immunologic level.
And, it's maybe a good segue because, Sattva switched gears there towards the end of his talk and went a bit more translational and started to ask, some of the questions I think the field is really struggling with about, mechanisms of resistance, and are there potentially going to be biomarkers here that may better inform how to make the therapy more effective and to minimize failure. And so, what was your sense there? If you had to highlight, a couple of key points from your standpoint, when you looked at the end and talked a bit about CD4 cells and antigen loss and what have you, what do you see?
Well, I think product characterization is an important thing, and we've spoke about this before, and there's more than enough really excellent scientists that they understand immunology very well that I think we should let loose into this area and help us as clinicians to understand what's in these products, the characterization. I mean, look, I think the CD58 story but the data that came out really was quite compelling, preclinical models to back it up. So there is a lot going on, and kind of like you suggest, right now as clinicians, we just see things. So some patients you see terrific responses, they're durable, everybody's happy. Some people you see a response and then they lose the response, and what's happening, not really sure. And our next steps to try and mitigate or to try and treat that, we're guessing a little bit. So it comes back to something you've always said: if we can pick the right patients, the efficacy is going to follow. And there presumably are biomarkers that help us really to pick the right patient for this type of therapy. So again, a fantastic talk and update, but just reminding me that there's still work to be done, I think, at a scientific level, kind of now from clinic back to the bench to try and sort out some of these issues.
Yeah, and it's good context, because as we maybe come full circle to what we were talking about in the very beginning of this discussion around the presentation, in Canada, as other centers are coming online, there's going to be opportunity to think about constructing those biobanks, to building in rich translational work, and kind of really ensure that we can get as much out of each case to really learn about what went well and what didn't. And so hopefully there's opportunities again in Canada where there has been history of collaboration, to really continue that. Looking forward, I think the rest of the meeting is going to provide a ton of context about how to interpret some of the results, in the indolent lymphoma session, or when they talk about mantle cell or DLBCL, CAR T isn't being developed in isolation. There are a number of other things, bispecific antibodies, novel ADCs, et cetera. And so, we're in a good spot again in lymphoma now, having additional tools that are going to be available to help manage patients. But, it's a good reminder to still try to get mechanistic understanding so that we can figure out who needs what and when.
Couldn't agree more.
Okay, so I think we both found Satva's talk, I think a good review and a good reminder about what's been done and what needs to be done. And again, thank you to the audience for your attention, and we look forward to seeing you at more events like WHU. Thank you.
Thanks, John. Thanks, Care.